Hi, it's Medic 360, your trusted hub when it comes to access to medical information and then professional advice. I warmly welcome you all once again to the platform and to our first session of our clinical case presentation series. If you are new here and then yet to subscribe, I'll implore you to hit on the subscribe button, turn on the post notification bell to receive timely information as and when the channel becomes updated. Today on the bill, we have a very interesting but delicate matter for discussion. Delicate in the sense that although majority of the people living in our population suffer from this condition, it is left undiagnosed because they barely confide in their clinicians and are usually shy to talk to them about matters of this sort. The very few that confide in their clinicians even have the fear that they might not get the right treatment regimen tailored towards assessing their needs and solving the matter as practicable as possible. The topic, therefore, for our discussion today is female sexual disorders and erectile dysfunction. The first section of the discussion will focus on the female sexual disorders available or that exist, and the remaining aspect or remaining section will focus on male erectile dysfunction. Let's go. So let's all have a critical look at the picture we have on display and then draw our individual conclusions. And then straight away, everyone will agree that both partners are exhibiting some signs of dissatisfaction, some signs of depression, some signs of distress, and then some signs of anger to some extent. Okay, and then if this is how your sexual activity ends in about 75% of the times, lasting for about 6 months, then I can promise you that there is a clinical problem that needs to be assessed and then managed. Female sexual disorder can then be conceptualized as any sexual complaint or problems resulting from disturbances in desire, arousal, orgasm, or sexual pain that causes marked distress or interpersonal difficulty. Okay. All that this paragraph is trying to put across is that for a problem or a complaint to be labeled as a sexual disorder, it needs to satisfy certain conditions, okay? It needs to bring about disturbance in the female's ability to achieve desire or sexual drive, to achieve sexual arousal to and sexual excitation or sexual pain that causes significant distress to herself or to her partner. About 40% of females are being afflicted by this condition, but it is barely reported to the hospital. Very worrying. Nevertheless, it is worth noting that the major clinical complaints among women center on their dissatisfaction with such non-genital behaviors as affection, communication, and non-genital touching, as well as issues of attraction and passion. Simple, okay? And then in brief, to be as concise as possible, it is not always about touching the right spot or stimulating her the right way or by touching her most sensitive part. It mostly boils down to their dissatisfaction that stems from problems of affection, problems of communication, and then issues of attraction and then passions with their partner. Okay, partners that have limited affection for each other and then don't have sustained communication or fluidity in communication, or they have some level of strained communications, tend to have problems when it comes to sexual function. Okay, and then there needs to be an element of attraction that attracts one partner to the other, making him more appealing to the other. Okay, and then a strong passion existing between the two parties to ensure that sexual satisfaction is achieved. What are therefore the types of the female sexual disorders that exist and the causes of these female sexual disorders? Okay. These slides will help us to assess and analyze most of them. The first type of sexual disorder that exists in a female is the hypoactive sexual desire disorder.
ladies or females that are classified as having this disorder tend to have little to no desire in engaging in sexual activities because their sexual drive or sexual desire is so low. Among the factors that account for this disorder includes psychological factors, emotional or physical distress. As central as sex or sexual activity is, any activity or any factor or any distress in the lady's psychological state or emotions, name them, being it anxiety, depression, physical and emotional stresses from any source, tends to impinge on their sexual drive, hence predisposing them to developing a hyperactive sexual desire disorder. Menopause, decreased hormonal levels. Now, menopause is accompanied by a decreased hormonal levels. And then when I talk about hormonal levels, I'm much particulate about estrogen and testosterone. These hormones have been scientifically proven to heighten a lady's chances of developing the right sexual drive or having the right sexual drive. Progesterone, on the other hand, is known to suppress sexual desire. Okay, so indirectly, what I'm trying to say is the more appreciable amount of estrogen and then testosterone you have in your system as a lady determines how good or how well your sexual drive is going to become. Okay, if it is on the low, then you are more likely to have a very reduced sexual desire or sexual drive. Medications such as antidepressants, anxiolytic, antihypertensive medication, not all of them, in fact some, are known to reduce sexual drive because of their effect on the central nervous system. The second sexual disorder that exists is the female arousal disorder. Okay. Now, females might have the right sexual disorder, but they may fail to achieve the required physiological and genital arousal required to ensure efficient or to ensure the right sexual function. Among the causes of this disorder include psychological factors as stated initially, stress, anxiety from any source, trauma or surgery. There are certain anorectal surgeries such as hemorrhoidectomy that have been proven to have effect in the arousal of the female because of how intimate the anorectal region is to the pudendum. Okay. And then trauma of any kind, whether an emotional trauma or a physical trauma, goes a long way to impinge on the female's ability to achieve the right physiological and genital arousal. Some medications have also been proven to suppress the ability of the female to achieve the right sexual arousal. The next female sexual disorder that exists is the female orgasmic disorder. Now, a female can have the right sexual desire or drive and might be able to achieve the right physiological and genital arousal, but might not be able to reach peak sexual excitation or sexual excitement. And then when this happens, in most of the times in a female, she can be classified as having a female orgasmic disorder. Okay. Among the causes of this disorder includes emotional or sexual abuse, rape. So individuals who have been raped or have a history of rape tend to interpret sexual excitation as a painful experience. And then when this happens in most of the times, they most likely lead to having a female orgasmic disorder. Decreased hormonal levels, i.e. testosterone, estrogen, trauma or surgery, like I initially said, some anorectal surgeries, okay, and then trauma of any sort. Medications such as amphetamines, antipsychotics, antidepressants, anxiolytic, and then antihypertensive drugs have been proven, or some of them have been proven, to reduce the females or to reduce a female's ability or female's chances of reaching peak sexual excitation. The next or the last sexual disorder that we're going to discuss is the female sexual pain disorder, okay, dyspareunia or vaginismus. Dyspareunia simply refers to painful sexual intercourse or penetration, whilst vaginismus refers to painful rhythmic vaginal contractions, usually from psychological factors, or even sometimes from vaginal disorders, either rising from the anatomy, the female's vaginal anatomy. Okay. Among the causes of female sexual pain includes psychological factors, vulvovaginal infections, endometriosis, medication that causes decreased vaginal lubrication, example benzodiazepines, some antihypertensive medications, certain anti-cancer medications, decongestants, and then estrogen modulators. Now you need vaginal lubrication to ensure that friction is on the lobe, and this will go a long way to reduce any pain whatsoever, okay, in or during vaginal penetration. Okay. Now, vulvovaginal infections causes inflammation around the genital region, around the vaginal region, and then whenever there is friction, whenever there is penetration, you are bound to have pain. Okay, so these are the types of female sexual disorders that exist. Having been informed about the types of female sexual disorders that exist and some of their causes, what therefore is the way forward? So you have to seek medical counseling and confide in your clinician as much as possible. Do not be discreet when it comes to information. Okay, open up to him as much as you can. This will ensure, or this will go a long way to help him to delve deep into matters and ascertain the root cause of your problems, and to fashion out the right treatment regimen required for you. Okay. Psychotherapy, geared towards promoting changes in attitudes and sexually relevant thoughts, is recommended. This will go a long way to diffuse any wrong misconceptions and perceptions that has been formed about sex in the individual, and to help him to motivate him to focus on the more relevant aspect of sex. You get it, and then this will go a long way to improve her sexual function. Be a partaker in your treatment modalities to help your clinician arrive at medications or plans that will not interfere with your sexual function. Okay, so if you're on any medications, or if you have been kept on any, medications, you can quickly do a quick research on the medication, and then if you find out that it is, it has a role to play in your sexual function, you can as well communicate with your doctor, and then he will help you arrive at the right medications that will not impair your sexual function. Okay, majority of our females don't do this. It's not just about issuing drugs. Sometimes when you issue drugs or medications to you, try as much as possible to do some sort of a due diligence. Okay, and then if you have any doubt about the effect the drug is going to have on your sexual function, open up and then discuss it with your clinician. Now, report any abnormal vaginal discharge or pelvic discomfort to the hospital for appropriate management. Now, we know that the other type of female sexual disorder that exists is the pain, or the female pain sexual disorder. Okay, now abnormal vaginal discharges, like I said, causes inflammation, and any discomfort around the pelvic region will predispose the person or the female to having a female pain disorder, female sexual pain disorder. And when you are reporting to the hospital with this condition, the doctor will help you fashion out the right regimen or the right appropriate treatment to help salvage the situation. Medications such as estrogen and testosterone analogs, first generation antipsychotics or bupropion, as well as PDE5 inhibitors, may be prescribed to enhance sexual function. Okay, now each of these medications that have been listed have their target groups. Okay, individuals with low sexual drive or low levels of estrogen and testosterone might benefit from estrogen and then testosterone analogs. And then individuals that are facing some sort of an emotional distress or anxiety problems, impairing their sexual function, might benefit from some first generation antipsychotics. Now, Ayurvedic such as Vivaduna also has proven clinical efficacies, and then I can attest to that because I've prescribed it on a couple of cases, and the feedback that I get is great.
So let's hop on to the next part of our discussion, which focuses on male erectile dysfunction. Okay. Now, erectile dysfunction can be defined as the consistent or recurrent inability to attain and or maintain penile erection sufficient for sexual satisfaction. Okay. Now, any male that has problems in his ability to attain and or sustain this penile erection sufficient for sexual satisfaction, which is a two-way deal, personal satisfaction and partner satisfaction, can be classified as having a male erectile dysfunction. So regardless of the cause, however, erectile dysfunction can have negative effects on a person's self-esteem, relationships, and overall quality of life. Okay. Now imagine, after all the coo and then you're cooing, your partner decides to, let's say your crush decides to meet you up, and then you both have, your good time in some, coded location. And then after all the ranting, and then you go and then underperform. And if I talk about underperforming, you don't achieve the right sexual satisfaction, and then you are unable to give the right sexual satisfaction to your crush. Then it is, so normal that your self-esteem, okay, or you begin to doubt that manhood, complementing you, okay. And then this goes a long way to strain certain relationships you have, either with your partner or with anyone, whether your wife. There's going to be some sort of, a strained relationship between you and the person, and then generally to your quality of life too. Okay. So therefore, a detailed medical, sexual, and psychosocial history is essential in uncovering the causes and also fashioning out the right, management for the erectile dysfunction. Among the causes of erectile dysfunction includes psychological and emotional concerns, especially in younger men. So gone were the days when erectile dysfunction was seen as a condition that usually affects male adults in their older ages. The narrative is changing because current research also suggests that younger men who are undergoing some level of a psychological distress and then marked emotional distress are at risk of developing an erectile dysfunction. Okay. Now, disease conditions such as hypertension, cardiovascular diseases like vascular insufficiencies, diabetes mellitus, hyperlipidemia, benign prostatic hyperplasia, and genitourinary infections such as STIs and UTIs can predispose one to developing an erectile dysfunction. Okay. Central nervous system injuries and then trauma and neurological dysfunction such as strokes and then multiple sclerosis can also predispose a male to develop an erectile dysfunction. Anatomical defects of the genitalia, example hypospadias, a condition in which the urethral meatus opens in the more ventral surface of the glans penis rather than opening at the tip, predisposes males to developing an erectile dysfunction. Medications such as some antihypertensives, example methyldopa, antidepressants, anti-cancer medications, and antipsychotics, example risperidone, has been shown to reduce sexual function and therefore predisposes men to developing an erectile dysfunction. Smoking and then alcohol usage to a larger extent also predisposes males to developing an erectile dysfunction. How, therefore, must we work up our patients who present with problems of erectile dysfunction? One, we have to bear cognizance of their vital signs, to check their blood pressure and then their blood sugars too, as we have been informed about the fact that hypertension and diabetes mellitus can contribute to the development of an erectile dysfunction. Okay. And we have to carry out a physical exam to assess the state of the penis and the prostate to rule out or confirm any anatomical anomalies and also any pathological changes in the prostate, and then to also assess the size and then the texture of the cervixes for disease progressions.
Okay. Now, a hormonal profile can be requested to assess the testosterone level present in the male. Okay. A serum PSA, a glycated hemoglobin, and a lipid level check can be requested or must be requested to assess the state of the prostate and then the blood sugar control or the glycemic control, as well as the amount of fat or cholesterol or lipids the person or the individual has in his or her system or blood. As we all know that benign prostatic hyperplasia, diabetes, and then hyperlipidemia can also contribute to the development of an erectile dysfunction. A urinalysis must be conducted to confirm or rule out genitourinary infections and then STIs too. Okay. Now, a USG of the penis goes a long way to help us assess the blood flow within the cavernosus or the erectile muscles of the penis. Okay. A transrectal USG must also be requested or can be requested to assess the state of the prostate to rule out or confirm any disease changes in the prostate. Having been informed about what an erectile dysfunction is, its causes, and the workup, what is the way forward with respect to the management of this condition? Now, we expect patients to confide in their clinician as much as they can and don't be so discreet. Okay. It is expected of clinicians to also offer sexual counseling that is geared towards identifying underlying psychological problems and promoting sexually relevant thoughts in younger men that are suffering from this condition. The management of the medical causes of erectile dysfunction must be also targeted aggressively. Avoid multiple sexual partners, avoid alcohol abuse and then smoking. Surgery is also recommended to correct penile anomalies as well as other vascular diseases that impinge on the sexual function of the male. Lifestyle modifications geared towards maintaining or reducing weight and improving cardiovascular function is recommended. Okay. Now, there are an array of medications to select from based on the clinical needs of the patient. Among them include testosterone analogs for males with low testosterone levels, phosphodiesterase 5 inhibitors such as sildenafil and tadalafil, prostaglandin E1 injections, example alprostadil, as well as Ayurvedic drugs such as Sanctus Royal, Manap, and Uthin have proven clinical efficacies too. And that brings us to the end of our clinical case presentation series for today. I hope this presentation goes a long way to help us. Feel free to drop your questions and contributions in the comment section, and I will be glad to attend to them all. I surely will be back.